And that should take us through to my fat head. Hi, everybody, and welcome to AskMED. We're doing things a little bit differently this month. We usually do this broadcast answering paramedic questions from our catchment area. This is coming to you from CPR, the Center for Paramedic Education Research, the base hospital. Normally we run this live on YouTube, but we're actually admittedly recording this a couple weeks earlier for a couple of reasons. I'm going to be busy with some post-op recovery at the time, so I won't be available. And I think Dr. Miller has the better option where I believe he's off skiing. So he'll be on vacation for the day that we put this out. We didn't want to change the release date. So, we're recording this a bit early to get things out of the way here. Let me put up the image of who we're joined by here. We have Dr. Paul Miller, Dr. Ian Buchanan, and we have Carrie Schneider from our quality team giving us a little bit of the paramedic perspective on some of these questions. How is everybody?
Good. Great, Rupi.
That also doubles as a sound check, of course. Got a few good questions here. And of course, if you're watching this and you are looking at, sending us questions, we can't do this without your questions. So certainly please do send it to us. The address should be up on the screen there. Send us email at askmed@cpr.ca. We really appreciate those, and it helps us to get our think on. Let me dive into some of these questions here. The first question is with regards to indications and contraindications and so on for dopamine. The question is, I recently attended a bradycardic patient with an inferior STEMI, so both bradycardic and inferior STEMI, which sometimes goes together. And this got me thinking, dopamine is a treatment in the bradycardia directive, and dopamine is a treatment in the STEMI cardiogenic shock directive. So you would think it would be a top choice if the patient had both bradycardia and STEMI. But the question goes on and says, I understand that dopamine could actually be harmful in the case of a bradycardic STEMI patient. Bradycardia is listed as a clinical consideration where we could consider patching to the BHP, but why isn't there a formal heart rate restriction or a mandatory patch point in the directive? And I think,
I'll take this one.
Go for it.
Oh, so I think all of us felt like this was a really good and complicated question, right? These are complicated cases, right? Cardiogenic shock, bradycardia, in the presence of STEMI, some of the sickest patients you'll see, and very nuanced, I think, in terms of the treatment modalities that will be employed in hospitals, sometimes with drugs that often, almost always with drugs that we don't use every day, to both do treble and bass, right? To try and adjust heart rates without asking too much of hearts that are in the midst of an MI. And likewise, getting patients rapidly to definitive care, which has more to do with revascularization and cath lab, maybe rate control with things like transvenous pacing, than with any particular medication, because we all know that the medications all come with real upsides and downsides. These problems for patients tend not to have as many medical solutions as they do interventional solutions like cath, like pacing. And so diesel therapy is one of the things that I would say in this patient population, of course, should be prioritized, and ideally to a center that has some capacity, like a cardiac center. But that's not part, other than through the STEMI, I guess, would get you to your HIU pathways. And whether HIUs can actually manage shocky patients is also another good question, not asked here, but how sick is too sick for a cath lab is an important consideration. And so you want to make sure, of course, the cardiologists are aware of how sick these people are, and they may well tell you to take the patient for stabilization elsewhere. But that's a different question. The question here, role of dopamine, is a treble and bass thing. There's pluses and minuses to it. And it really has to do with the fact that the bradycardia gives you a hint that there's likely RV involvement. And as we know in other contexts, STEMIs with RV involvement are different beasts than STEMIs that are just left ventricular. And part of that is because of how volume sensitive the right side of your heart is in comparison to the left. And so, while dopamine can help with bradycardic patients that are not in the midst of STEMI, when you apply it to patients with STEMI, particularly with right ventricular involvement, you may be asking too much of the heart, or resolving, for instance, the heart rate, while not resolving the issue of volume-dependent right ventricle. And so you can create a scenario where you're not helping and might be harming, just allowing the patient to do, the heart to do what it's capable of doing in a moment. These are really great calls for patches, and what I really like to see is how come there's not a mandatory patch point here? Shouldn't there be? And I would come back on what we've been talking about for years, which is getting rid of mandatory patch points and really trying to instill in paramedics the desire, the want to call for backup from an agency like OMC, like your base hospital docs, when you feel you need it, when you want that consult for clinical reasons. So please call. Have we inserted a mandatory patch point here? No. Could we? Sure. But what I love about this question is, but this is where it's really complicated, and we should be getting multiple people's brains thinking about the same clinical scenario. God bless you. Yes, you should. And so please call, and we can help. At the very least, what we can do is hopefully take some of the really complicated pharmacology and physiology off your place, and give you some advice while you are doing the hard work of getting those IVs in and mobilizing a patient and driving and making other decisions, without having to think about cardiac receptors in quite that level of detail. And so these are complicated cases. Dopamine will often play a role in patients that are really shocky because there's no better option. Although so too will a bolus of fluids often help, even in patients that might be getting into congestive heart failure or true cardiogenic shock. But that volume for the right ventricle can still be helpful. That's not part of any of your directives either. It would need to come with a patch.
I think
nitro will really hurt these people, so you would avoid nitro in these cases. And there's lots of red flags there. These hypotensive, didn't mention that in the question, but I'm going to assume it based on the way you described it in the role of dopamine. Bradycardic and likely right ventricle involvement. A spray and nitro here will really drop the boots out.
And it's interesting because, I mean, it's almost like for this particular scenario, the things that dopamine does kind of undoes some of what the body's doing to try to compensate. So when the heart rate drops in this kind of RV failure, it's actually a good thing, because you end up in a situation where the RV has more time to fill. And so maybe with its limited capacity, that might help to squeeze a little more blood around. You don't want to crank up the contractility of the left ventricle too much, because now you've got resistance and the RV is trying to do its thing. Whereas with some of those other indications, when the left ventricle isn't working too well in the STEMI, then, dopamine's great for getting your contractility going. For a patient who's purely bradycardic without ischemia, it's great for getting your heart rate up. But this is an interesting intersection where understanding the physiology, it changes things. And I think that's why the patch is encouraged. Even if the patient's heart rate wasn't affected, the RV wasn't pumping, you still have the same problem. So I think it's kind of hard to put a specific number on what heart rate should you never give dopamine at, because that's not really what you're dealing with. It's that recognition that the RV might be involved.
Paul, you did have a question about whether this patient was hypotensive or not. I think it's a good question overall. When I work, we review ECGs all the time, all shift long. And oftentimes nurses will bring me an ECG quite worried about a heart rate outside of STEMI, but just a patient with a heart rate of 35 or 40 and be quite worried. And my first question will be, well, do they have symptoms? Do they have hypotension? Are they feeling lightheaded? And so if in this patient, they're having a STEMI and their heart rate is 45, maybe I don't care to treat at all if they're asymptomatic otherwise. So if they're normotensive and, aside from their chest discomfort, aren't feeling presyncopal or unwell, I think putting the whole clinical picture into context, I think, is important in these patients, because, maybe doing something carries some risk of harm, whereas, just getting to definitive management is really what the patient needs overall.
Very true. I like that. Thank you.
And that's where that comment about diesel comes in handy, I think. Let's move on to the next question. I hope that that covers it. Like I was saying in our sort of pre-broadcast chat, there's some really interesting physiology here. So the question really gave us a chance to dig into that. Thank you for that. Question regarding pad placement, pretty straightforward. AP versus AL pad placement. Is there a preference? We get this a lot, and it almost feels like the evidence is kind of moving on this, because you hear some people say one, some people say the other, and there are different indications for electrical therapy. In some cases, we're talking about delivery of shock in cardiac arrest. We're talking about delivery of shock in elective cardioversion or cardioversion in shock. So there's a question about which part of the heart you're actually trying to catch in that vector. And a lot of the evidence that said that you want to use one over the other comes from old data with monophasic shock delivery. Whereas most of our, I assume all of our cardiac monitors and defibrillators are biphasic at this point. What we've seen is that with the biphasic shocks, it seems the vector overall doesn't seem to matter as much, as long as you've got good delivery of shock to the heart. And that's all about what configuration the heart is in relative. So AP versus AL, there's the evidence says there's not a whole lot of a difference, but you have to think about exactly what it is you're doing to the heart, and whether or not that shock is getting to them. And I think, Carrie, you had some thoughts on some of this confusion as well.
Yeah, we get this question quite a bit, and fantastically, your 2026 APR is going to be focused on cardiology and cardiac arrest management. So there's going to be teaching throughout the year on this. In the answer of which is the superior placement or where do I start, right now our answer is either are acceptable. Reason being, there's two competing priorities here. There is some research showing that the AL placement may defibrillate more of the left ventricle, so you may end up getting a larger chunk of that heart defibrillated, which is why in some areas around us, you may see AP as the preferred pad placement. But that also needs to be balanced with time to first shock. So you're going to hear over and over again in your APR that the two most important things on an adult medical cardiac arrest are CPR that started early and as uninterrupted as possible, and then early identification and defibrillation of shockable rhythms. So your AL placement, if you have someone that you arrive on scene and is in cardiac arrest and laying supine, may be a faster application to get that first interpretation and potential shock in nice and early. If you have a patient who's alive when you get to them and you identify a STEMI and you have time to place pads AL, or as Dr. Saucy indicated, you're looking at pacing or cardioversion and you have time to apply pads that way, that's also a fine way to start. We've also, we're going to run into vector change, I think, in the next question, but doctors, you want to add anything into that from a practical standpoint? Paul?
I would say I think the evidence is changing and evolving as Rupi talks about this. And part of it is the really important work that Sheldon Cheskis has done just in a neighboring city here in Peel, and other services, maybe some of you who are listening to this call. And so his work around dual sequential, and which included vector change, really saw a benefit with vector change. And having spoken to Sheldon many times about it, his interpretation of the data is that the vector change was moving from a poorer vector, AL, to a better vector, AP. That's his supposition. And I know that there's some research coming potentially to explore that in clearer, to build the evidence around maybe there is a superior placement. And if there is a superior placement, do we know it? And have we tested it with, as Rupi talks about, the sort of the modern equipment that we have now? And that would need to be replicated many times. I think I'm not the AHA, I'm not ILCOR, but those kinds of bodies look for evidence to be replicated over several studies in multiple jurisdictions to then make a guidance or make a recommendation of there is a preferred approach to, for instance, pad placement. We're not there yet, but there's certainly a hint in the science that AP may well be superior to AL, with the caveat that Carrie gives us about time to first shock is still a really important outcome. And so it's balancing the delay, if there is one, to what might be a more superior, a better placement. And I think we don't really know that yet. And certainly the groups that we look to, like the AHA and ILCOR, to tell us how to do these things don't have a clear recommendation.
Yeah,
Yeah.
I get this a lot in Emerge when dealing with atrial dysrhythmias, and I do know there was some recent evidence that said that for that particular entity, that AL placement might have a slightly higher first shock success, but the actual degree to which it gives you better first shock success is fairly minimal. And again, we're talking about atria at that point, which doesn't generalize to ventricular shocking in cardiac arrest, which we really do need to treat as something else.
One of the things I'd say, if anybody gets an opportunity to listen to Sheldon speak on these matters, he really is such an enthralling speaker and really knows this stuff. He's doing world-leading research on it, and so if you get a chance to hear him, go pay whatever it is.
Yeah, and he's just plain fun to listen to. Like, he's just a really entertaining, engaging guy, isn't he?
To close up this question, one question we do get quite a bit, particularly from PCPs who may not have used AP placement in a long time, is how exactly to place the pads. Look this up if you have questions. It's on the Zoll website. I believe it is in your app or directive book as well. It's not a sandwich right directly central to the heart. It is over towards the left. So little things that seem little, like correct pad placement, makes a big difference too in the success of your defibrillation. So that would be one of the things to maybe troubleshoot if you are shocking a rhythm repeatedly and not getting a change. Yeah.
Yeah, I think we spend a lot of time talking about pad placement, but there are some of those fundamentals that probably make a bigger difference than exactly where the pads are being stuck. I mean, the research questions will answer some of that along the way, but based on what we have, the things you want to concentrate on is getting that first shock in early, making sure your pads are on correctly, that you've got good contact, you've reduced impedance, your cables aren't loosed, things are stuck the way they're supposed to be stuck, and then recognizing when your shocks aren't working, how to troubleshoot that, and when to do vector change or dual sequential. Ian, you got anything on this?
Oh, I was just going to say what you said, Rupi, in terms of quality of pad placement, making sure there's no wrinkle, making sure there's not a big sort of mat of hair underneath the pad. Sometimes even if it's poor AL placement, if the fastest thing is just to like pick the pad up and put it back on in the same place to interpret and deliver first shock, the quality makes a huge difference to effectiveness of shock delivery.
While we're on the subject of shock delivery, we'll move on to the next question. Carrie already alluded to the topic of vectors. The question was, in a patient with refractory VT-VF, where we have made a decision to transport the patient early, do we transport after the first 3 shocks like we would do conventionally, or do we change the vector, shock 3 more times, and then transport? Carrie, you're grinning. Go for it.
All right. This directive did change with our last update. So it's written slightly different PCP to ACP, but essentially the end meaning is the same. In the case where you are shocking repeatedly, what our directive says is 3 shocks in the pad placement you start with, then a vector change to the opposite pad placement, and then 3 more shocks in that pad placement, and then transport. So this was born out of questions of, when do we transport in shockable arrest? Do we transport early because they're more viable, and then maybe lose out on some of that ability to shock in the regular 2-minute interval? Or how long do we stay on scene if we have someone that's in a refractory rhythm that isn't coming out of it? Where is that line of diminishing returns? So this is the balance of trying to get 3 shocks in your original position, doing a vector change, 3 shocks in to give the vector change an opportunity to work, and then recommending rapid transport. Add-ins?
Yeah, I think the way I think about it is that, I mean, a lot of the times when you're thinking about early transport, you're talking about doing 3 shocks, then getting in the truck. For these, you have to assume that if the patient is still in a refractory VT and those shocks didn't do anything, you don't consider those to be particularly effective shocks. And we've said over and over again that it's time to delivery of the first effective shock that makes that difference. So now you're dealing with somebody where you're doing CPR, you've given 3 ineffective shocks. If you package the patient up to be transported at that point, there are going to be interruptions in CPR. All of that perfusion pressure you've built up in the coronaries is going to be interrupted. It's going to take you a while before you are in a position where you're going to deliver those subsequent vector changed shocks. that's a lot of delay, and that's going to inhibit the efficacy of that subsequent shock in undoing the ventricular dysrhythmia you're dealing with. So it makes a lot of sense to reduce the delay to effective shock once you've identified that vector change is going to be needed, which is after those first 3 shocks didn't work. Just get to it. Paul, you're sort of you look very pensive. I have the feeling you wanted to.
Pensive because, but I agree with all this. I just think about how stressful it is to have patients who have shockable rhythms that don't respond to our shocks. It is. It's a particular clinical entity for me that I just want to fix it. And sometimes these things come back so quickly that you're like, oh, great, like this machine worked and saved a life. And other times you're like, why isn't the machine working? It's supposed to work.
Yeah, it's when you know. Sorry.
That sense that time is both speeding up and slowing down with these cases. Yeah.
It's also that mentality I find of, okay, I've got the next step. I have to do the thing that works. Why is that thing not happening? Please do the thing. Let's get away from cardiology. We've got one more question here, and that's with regard to postpartum hemorrhage. In the treatment of postpartum hemorrhage, there's understandable emphasis on oxytocin to increase uterine tone. Would calcium or TXA have any role? Could calcium possibly increase the ability of the uterus to contract?
Yeah, I can address that one, Rupi. So we've been getting lots of questions over the last year, probably based on the recent education cycle for a couple of aspects here, both for introduction of oxytocin as well as some chatter about TXA in the last 12 months. Let's take this piece by piece. So oxytocin, absolutely. The question itself identifies that this is a priority in managing postpartum hemorrhage. So I don't think there's any real question or doubt there. Speaking about TXA and calcium, we'll take them in sort of 2 separate parts. The simple one is TXA, I think. TXA acts as an antifibrinolytic and so stabilizes clot that's forming in the body. And so just like in traumatic hemorrhage, has a place in postpartum hemorrhage as well. So definitely worth a call to OMC to discuss administration in these patients. And there's actually some evidence that shows that it is a life-saving medication with postpartum hemorrhage. So totally agree that there's a role for TXA in these patients. Anybody else have any comments about TXA before we move on to calcium?
I always like to point out with TXA, some people argue about its place in pre-hospital versus hospital environments. And there's lots of good data that shows that for patients with significant hemorrhage, whether postpartum or otherwise, the sooner you give the TXA, the better the result. And so I do think there is a role pre-hospital for TXA administration. And this would be a good example where patching would be very helpful. But you don't want to do concentrate on TXA to the exclusion of all the other stuff you should be doing. So uterine massage, oxytocin, you want to get the tone of the uterus to do the work for you. But yes, if you've taken care of all of those things, you still have bleeding, then yeah, patch for TXA.
Yeah, totally agree, Rupi. And the nice thing about TXA is that its safety profile is excellent for the pre-hospital environment. So the question about calcium is, again, one of those sort of deeper dives into physiology, and maybe one of those circumstances where what's sort of seen happening in the context of massive transfusion in the hospital, maybe somebody is receiving calcium, or you've noticed after, transfer of care has been achieved and you're, hanging around to see, what's happening to a patient before you get on to your next call. You may see some calcium administered there. So that begs the question, why aren't we giving calcium before the patient arrives at hospital? So excellent question in that regard. So when we see calcium given in the context of hemorrhage, it's almost always in the context of massive transfusions where after receiving a number of units of blood, there's the side effect of one of the additives to the packed red blood cells. It's called citrate. That's there for a couple of reasons. One is a preservative, and secondly, to absorb or chelate all of the calcium that's in those packed red blood cells to prevent unintended activation of your coagulation cascade. So when patients are receiving many units of blood, that citrate will serve to chelate the calcium that's systemic to the patient. And so they can wind up symptomatically hypocalcemic. And so those patients were following calciums closely. And even after a certain number of units of packed red blood cells, providing calcium supplementation to patients receiving massive transfusion. So to back up to the original question about whether there's a pre-hospital role, the short answer is no. You're likely not there yet in terms of iatrogenic or unintended injury or complication from the blood transfusion. And the likelihood that the patient themselves, all other things being equal, is hypocalcemic to begin with is very low. So likely the benefit in these patients would be very, very marginal. And then it's always the question of where is the patient best served, receiving therapy. And so if adding another medication would with limited benefit would delay transport to hospital, probably the risks of giving the medication in that regard far outweigh the benefits. So in my perspective, no real role for calcium in the pre-hospital environment in these patients.
And I like the way you sort of talked about the way that calcium drops in massive hemorrhage and what causes that. There is that thought, because a lot of posts and articles talk about the lethal diamond of massive hemorrhage, adding that hypocalcemia is one of those elements that can lead down that spiral of death that we like to try to avoid. It's a question of when that hypocalcemia actually occurs. And yeah, it's probably not if the large amount of bleeding is probably not causing a low calcium sufficient to interfere with uterine contraction. I mean, yes, the uterus does need calcium to do that, but you haven't lost enough calcium. You haven't had those iatrogenic causes of hypocalcemia that Ian was talking about happen yet. So what's the calcium going to do? In fact, there were a couple of studies that I managed to pull out that looked at calcium, and unless the patient was already critically hypocalcemic, the calcium administered is not going to make the uterus clamp down any harder. So not really, I mean, good physiology to think about the things that are going on while you're treating the patient. But in this case, calcium is probably not going to do a whole lot. And you're probably, in the end, just giving more for the citrate to chelate later. Paul, we were talking earlier. You said that you've noticed, I've had as well, a lot of people who will often patch for calcium trying to get ahead of it. Have you noticed that?
Yep. In all sorts of hemorrhagic patients, I get the sense, although I haven't always unpacked it with the person calling after the fact, but I get the sense that it is try to front load this calcium issue for a patient that they know needs a massive transfusion, and I would say there's a degree of uncertainty about that as well, right? If your oxytocin and massage and things resolve this postpartum hemorrhage, that patient may or may not need a transfusion, and it may or may not need to be massive, even if it's one packed red cell. We don't treat with calcium after one unit of red cells, if that's all that a patient requires, for instance. And so the thought to try and treat now for something that happens 4 steps from now is the part that isn't required, and there's no benefit for it if that's what the motivation was for the medics. In a case like postpartum hemorrhage, the other motivation might well be, but wouldn't calcium help with muscle contractility or something? So maybe they were thinking about it from 2 different directions. But trying to get ahead of a patient who might need a massive transfusion, or even definitely will need a massive transfusion but hasn't had it yet, as Ian points out, no real benefit to that, to try and get ahead of it. We'll do it as part of the massive transfusion protocol.
And for these patients in particular, I will say that we have a couple of other medicines as tricks up our sleeve that can work quite quickly. They are sort of attacking the root causes, or some of the root causes of postpartum hemorrhage in a variety of different ways. And again, those are only medications that are available from pharmacy, in a hospital. And so, if you have a patient that is unstable and you've exhausted the options that you have available to you, in the pre-hospital environment. Just having an understanding that that we do have those other things available to us in quite a rapid fashion in the emergency department. They're on hand, in any hospital that has a labor and delivery ward, because we do see postpartum hemorrhage with some frequency, and so those are quite immediately available.
So I think that brings us to the end of our list of questions. In terms of topics that are coming down the pipe that we've been discussing at CPR, there's been a lot of conversation about implementation or re-implementation of semi-automatic defibrillators, SAED. Paul, you want to touch on that a little bit?
Thanks, Rupi. So this comes back to a topic that I think we've spoken about before, maybe on this channel, but certainly been talking about it in other places as well. That CPR is going to launch a sort of a Plan, Do, Study Act, a quality improvement initiative around our rates of defibrillation. And so really what we've seen is a bit of a trend of missed shock and or long delays to first shock, the time to first shock that Carrie mentions. And so we're going to approach this in several ways, one of which is through the APR that some services, one service in particular has rolling out effective today, around reinitiating or reauthorizing, encouraging the use of SAED. CPR was one of the only base hospitals to move to a manual-only approach, and that was many years ago. The science was pointed at that time to manual being superior to SAED. Medics were faster and more accurate than the robots. And since that time, the robots have changed. And maybe the medics have changed too, but definitely the robots have changed. And they are now approaching or superior to humans. And so I think we need to respect that and change our practice as a result of the technologies that you've been given by your services. All CPR services use some of the latest technology from Zoll. Zoll is not the only place. I try not to shill for a manufacturer, but the reality is that all of the CPR services are Zoll services currently. And so the time to first shock through Zoll's rapid shock software and algorithm, and the ability for medics to offload a decision during a critical time of resuscitation to a robot, I think are both useful and practical tools to use. And so that conversation, trying to both convince paramedics of the relative utility of SAED after many years of telling them and showing them that manual defibrillation and paramedic judgment was superior, will take us some time to get to everybody. And we're going to start that conversation with APR, and you should be hearing about it from your services over the coming year as we're encouraging them to include SAED as part of their annual CPR research, and being able to fully utilize the technologies that you have available. We'll be watching or measuring as part of a quality improvement process, is it making a difference to our time to first shock? Because of course, just simply deploying the robots is not sufficient, right? Medics need to prioritize that aspect, realize that there's a goal of time to first shock of 2 minutes from patient arrival, and be aiming for it aggressively as part of a pit crew type CPR response. And so with education and with feedback around how you're doing, and with the deployment of SAED and a multi-pronged approach, this is not just as simple as we'll let the robots do it, and therefore it will be better. I'm hoping that that's one of many tools that might make this better. And it needs to get better. We need to be sure that we're really focusing on that time to first high quality shock, and what does that mean? And that will take us some time to get to, both as the evidence changes, as I expect it might around vector change, like we've talked about, and also time to deploy the technologies that you have, like SAED.
Brilliant. Well, that brings us to the end of AskMed. Like I had said before, if you've got questions for us, please submit them. It really makes a difference, and we appreciate it. The address is on the screen, askmed@cpr.ca. Thank you all for this. Appreciate your time, and this was a good discussion, and I'm looking forward to the next one. I believe the next one is in May. The dates are available on our Facebook page or Instagram page, et cetera, et cetera. And if you want to get in touch with us through any of those channels, we usually have people keeping an eye on things. Paul, Ian, Carrie, thank you again.
Thanks, Ruby.
And we'll see you soon.
We'll be thinking about you this month, Ruby.
Thanks. We'll
be well, my friend. Recover rapidly.
We'll be back to kick some behind soon enough. Bye-bye.
Take care, everybody.